And perhaps you can do that by training. And the way the training module works is you position the circle where you want fixation to fall, and when the person gets it to be in there, you get like a continuous sound, and when they're not there, it's sort of like it gets, it's a broken up sound, and it gets louder and more confluent as you get close to the center. The thing is, I have not really used it for this at this point. There's some controversy as to whether you can actually define for a patient where their fixation should be, and I tend to go the other way. That is, see what they're doing. When they're reading a chart, are they missing the letters at the right, for example, which means they're looking to the right and moving the scotoma to the right of fixation, and try to reinforce that. But I will explore it in the future, and we'll have to see how it works. I tried it for one other thing, which I think has intriguing possibilities. When children have amblyopia, they have they have decreased vision, but it's not on the basis of any disease in the eye. It's because, so to speak, the eye hasn't hooked up properly to the brain. So they often have decreased vision. And in some of the patients, the one we tested was a patient with what's called microstrabismus. He had a tiny variation of where he put fixation relative to where it should be. So I actually tried on him, bringing him back for several weeks at a time and doing these sessions of getting him to try to put the fovea on the fixation target, because theoretically you should be able to do that. You should be able to get him to improve his vision. It was difficult for a number of different reasons, but I think it's and one of the reasons was that what he was doing. I'm saying put the fixation cross, put the circle over the fixation cross, but he sees a little piece of lint or something in the screen, and he knows that's when he positions it in exactly that position, the cross goes on the fixation mark, and then he gets the smooth tone. So I don't know if I was really training the right thing, but I think it has potential in that. I said all this. Okay, just a few more things. So there are certain diseases that require microperimetry, I think, more than others. In this was just published in Retinal Cases and Brief Reports. In geographic atrophy, really what you see is what you get. That is, this is a case I showed before. Where there's atrophy, there's a dense scotoma. Where there isn't atrophy, there's not a dense scotoma. And that's why I've argued in a number of different forums that for geographic atrophy itself, like if you were doing a clinical trial of that, I don't think that's the disease to do microperimetry in, because you really get your information just from defining the size of the area. But in contrast, in Stargardt disease, for example, the situation is not that simple. So here's a young woman with Stargardt disease. You can see she has all these flecks here, and she has this atrophic area in the center. At that time, she was actually 20/40 in visual acuity, and you can see all the blue spots are there. She had very stable fixation in an area within this area of atrophy, just had a little spared area. But what was interesting is it looked as though I outlined here where I would have drawn the borders of, if I had to guess where she didn't see, that would have been where I would have guessed, because that's where she had the obvious atrophic lesion. And when I tested her, it really was significantly past that. In other words, it didn't, unlike the previous case, it did not conform to the area of atrophy that I saw. And I tried it another way as well. You can do kinetic perimetry in the MP1. And for certain cases, it does a very nice job. And what I did in this case is you can do it from in to out or out to in. So what you have to do is you have to define where you want the center of the pattern to be. You define how far out, the radius of each meridian, and you can define how many test points you want. So this is 8 test points. And then what it does is, so it can do it in to out. That is, it can start from the center and go out this way, and go out from the center, or you can it starts out here and then it goes out, and the person has to push the button. In this case, push the button when you stop seeing the stimulus. Okay, that's what I was doing. So I was doing out to in, and the reason I was doing out to in is because if you think that the problem is, let's say, reaction time, for example, if somebody it took them a long time to react, then if I'm going out to in, by the time she pressed the button that she saw that the stimulus had gone away, I should have been in the middle of here somewhere. So in other words, going out to in will minimize the size of the scotoma, and yet you can see even here there was this whole area that I would not have called any different from the area outside that was seeing that was scotomatous. So it's very useful in a situation like that. And here's a patient who had a macular dystrophy with really the opposite issue. This drawing is sort of how I would have thought the scotoma would be to correspond to the atrophy here, but the patient actually had a much smaller scotoma. So again, these are areas, a lot of these atrophic diseases where the MP1 testing becomes very important in terms of defining where a person is seeing, where they aren't, in terms of advising them regarding low vision and hopefully for future clinical trials. It's very nice, as I showed you one other case before, for RP, for outlining where the area of vision is and getting really a precise degree measure of how large that area is, which is difficult to do by other means. Okay. And when you have central scotomas, when I work with patients, basically there are three modalities. Since they have reduced visual acuity, you need magnification. They have reduced contrast sensitivity, so you need things brighter and bolder. But the real limiting factor is this presence of a boulder, of this obstacle, this block in the field of vision, because we can always make things bigger. And if we didn't have this here, the person theoretically could be reading. They wouldn't read as fast as they did with the fovea, but they could read fairly well. But when you have to relearn how to read by learning how to move this out of the way, it's really no simple task. And we spend a lot of our time with scotoma awareness and helping a person understand what's involved in terms of getting rid of it. Because if they can't get it away, they can't see. I mean, no matter how large you make it, if it's still in the area of atrophy, they won't see it. And it's very inefficient if a person is, scanning all over the place and not being able to see. Let me just see. Yeah, okay, I want to just say a couple more things. This, as part of my geographic atrophy study, I looked at patients who had geographic atrophy in both eyes for whom I had follow-up of at least 3 years. And what I found was that the worst eye of these patients, in about 20% of them, they actually improved their acuity by 2 or more lines over the 3-year period. Now, this was while their atrophy was worsening. So it's not that the macular degeneration was getting better, and it did not improve in any of the better seeing eyes, only in the worse eyes. And I think the reason was initially when the better eye was sort of determining how the patient was using their fixation, what they were looking at, and when we tested the patients at baseline with the fundus perimeter, they often just put the cross right into the abnormal area and couldn't see it. But 3 years later, they were able to use eccentric retinal locations and therefore see more effectively. So I often tell patients that if they have people often come in, if they have one eye worse than the other, they say this eye is useless. And even though we can tell them, no, it has peripheral vision and so forth, they often think that way. And then they may come in at a subsequent visit and say, I think this eye is seeing a little better. There is more potential vision in there than they imagine. And that's something we have to capitalize on as well. Okay. Let me just see. Yeah. Okay. So just 2 more things, then we're done. Patients who have scotomas have to figure out how to move them out of the way, and the MP1 helps us a lot to figure this out, figure out how they're doing it. most cases, in general diseases, there are the two